Thank you very much. In this retrospective study, we extracted data from Maccabi, the second largest health maintenance organization in Israel, which identified more than 160,000 diabetic patients. In this study, we compared EGFR outcomes and clinical outcomes between patients initiated SGLT2 compared to patients initiated DPP4 during the first 2 to 24 weeks after treatment initiation. After aligning all inclusion criteria, 6,480 patients initiated SGLT2 inhibitors and 5,604 patients initiated DPP4 inhibitors. The groups were relatively comparable, even though the SGLT2 patients were slightly more younger, had diabetes for a longer time. Hemoglobin A1c was similar between both groups, but EGFR was higher, a little bit higher in SGLT2 compared to DPP4, but was similar when we stratify according to EGFR categories. Overall, adjusted odds ratios was 0.372 for having at least a 40% reduction in EGFR in SGLT2 compared to DPP4. And was 0.465 for hospitalization with ACI and 0.43 for all-cause mortality. By stratifying population according to EGFR category, odds ratio was higher, but not statistically significant in lower EGFR, and yet was significantly lower below 1 for having at least 30% reduction in EGFR. You can see this trend. While in any hospitalization and hospitalization for acute kidney injury, the trends of odds ratio was below 1 and similar in all layers. This one compared to this trend. In conclusion, our study demonstrated real-world evidence that treatment with SGLT2 inhibitors in comparison to DPP4 is associated with lower rates of renal adverse outcomes, hospitalization, and mortality within 24 weeks from treatment initiation. However, a greater decline in EGFR is observed with SGLT2 inhibitors primarily in patients with progressive CKD, mandating a close follow-up for this group. And I would like to thank for Avivit Khan and Gabi Chodik for all this work.